Okay, so good morning, everyone, and Merry Christmas to everyone. We are meeting with the National Medical Association on the day of Santa and hoping that this world will get into normal. And that is the all everybody's asking for the wishes. Good evening, good night, whatever, whichever country you are in. So we are joining in from a lot of places, and thanks to the speaker who is joining in at the midnight on the Christmas Eve. So we were having a discussion at night, and she was talking about the cases in US, and I'm very thankful that she accepted the invite for speaking up today. So welcome to Dr. K.K. Agarwal's Heart Care Foundation of India and CMAAO Collaboration International Weekly Meeting. We are on 90th episode today, and the topic for the day is USA and Omicron variant update. And we have among with us Dr. Monica Vasudev. She's an allergist and a clinical immunologist who is a fellow of American Academy of Asthma, Allergy and Immunology, and a fellow of American College of Allergy, Asthma and Immunology. She has graduated with a bachelor degree of science in biochemistry from McMaster University in Canada and pursued a medical degree from Bangalore in India from MS Ramaiah College, and also contributed as a group editor from IGCP Group. She has completed her residency of internal medicine, followed by the fellowship. She has a lot of publications in her name, a lot of chapters, 12 publications, 37 publications, and 4 chapters. And she's currently working for Advocate Era Health for the past 8 years. Over to you, Dr. Monica.
Thank you, Saurabh. It's always a pleasure to be a part of this August forum. Wishing everybody a very safe and very happy holiday season. I know it's not the holiday that everybody expected in this third season going in. However, I think this is an important topic because what's happening right now is affecting how everybody is spending the next while. I also want to thank all of you for your time and being here, especially during the vacation. I will share my screen now. So what you can see here is I will be presenting on the American and the Omicron update. And this is being done in continuation with Dr. K.K. Agarwal's legacy. And as we close in at the year, it's even more befitting to reflect upon what he single-handedly has done to the medical profession, not only in India, but for the rest of the world, and how his legacy has been carried through even by all of us who participate in this forum. So it's not a very happy thought right now to start talking about this. Seeing what the Worldometer statistics are, we see that there have been over 5.4 million deaths since the onset of this pandemic. And the United States is leading the toll. We have so far 837,671 deaths as of Christmas Day, GMT, 3:34 a.m. This is a very poignant moment to reflect upon what exactly has been not only on the toll in terms of fatalities, but in terms of the morbidity, the mortality, and the loss of our lives as we have known it. We had never expected to be where we are today, 25th December 2021, when this pandemic began at its onset in November of 2019. These numbers are staggering. Each one of these numbers reflects some loss, not only in life, but in the quality of life in those who have survived. And I don't think that the fatalities truly reflect the impact of this pandemic. I'd like to talk today a little bit about the background of the Omicron virus, a little bit about testing, vaccines, monoclonal antibodies, and pills. And important to reflect on that whatever I say at this moment will change again, whether it be an hour from now, a day from now, a week from now, or a month from now. The information that I present today is believed to be as current as possible, or as otherwise stated. So in this August forum, we have Dr. Coetzee, who was the one to bring to the world's attention the appearance of the Omicron variant of concern. And this is the editorial that she had written with respect to what her observations were regarding the variant that they had observed in South Africa. And I really applaud this, because had we known this in November of 2019, which we couldn't have at that time, but we would have had potentially a different trajectory in terms of the timing of doing things. And she faced a lot of conversation, is how I'll put it, from the world regarding her discovery and her reporting of her discovery. And I believe that we should all take her example and her lead in terms of how we report and how we continue to educate the world as to the current state of affairs. So how do these variants happen? Variants happen due to two major factors. One is that there's a high number of cases that increase the risk of mutations. The more the virus spreads, the more chance it has to mutate. Thousands of small changes have been seen in the coronavirus so far, mostly with little impact. So most of the mutations we see actually have no impact. But there are some mutations that lead to new variants. And that's how, and those variants give it qualities to allow it to survive. And it's usually about how, in the case of the coronavirus, due to changes in the spike protein that help it enter the human cell. So as you can see on the graphic on the right, you're seeing the ancestral virus that was detected in China in November, December of 2019. And then you had the initial B1 variant, which was in early 2020 in Europe. And you can see with the presence of alpha, beta, delta, and gamma until late last year in 2020, it took almost an entire year before the next major variant of concern came out, which was the Omicron, which was detected in November of 2021. So what is this? It's a variant that has more than 50 mutations. It was designated a variant of concern by the WHO on November 26th. It's been identified in over 90 countries. In early December, just a few weeks ago, a California resident who returned home from South Africa was the first identified American to be infected. We know that it spreads 2 to 3 times faster than Delta, and cases can double every 2 to 4 days. And it's 5 times more likely, you're 5 times more likely to be reinfected with Omicron compared to other variants of concern. So this new variant of concern has many novel features associated with it that are very concerning. This was a recent publication from the Hong Kong University, where they find that the SARS-CoV-2 virus can infect faster and better than Delta in the human bronchus, but with less severe infection in the lung. And what it's showing is that 24 hours after infection, the Omicron replicated 70 times higher than the Delta variant. And you can see this in the panel on the left. And you can see that it's written here 70 times greater than, for the Omicron, greater than Delta, than the original SARS-CoV-2 virus in the bronchial tissue. So in the bronchial tissue, the tissue of which you're expressing when you cough, you see that the Omicron is 70 times more in terms of replication. But it replicated less efficiently, which is 10 times lower in the lung tissue than the original SARS-CoV-2 virus. So this could potentially explain its high level of transmissibility, but maybe explain potentially a decreased morbidity associated with that. But we still have to wait and see what the true level of morbidity is associated with the Omicron. So I had said that there's about 50 mutations that were seen in the Omicron spike. What you see on the left diagram is the top view. The deletions are seen in the gray, and the mutations are seen in the golden color. And you can see where on the spike protein that these mutations are affected. These mutations have not been seen in combination before. There's about 30 or so mutations in the gene for the spike protein for which the corona uses to attach to human cells. So that allows it to enter the cells much easier. And the Omicron spike protein has several mutations that are found in other variants of concern that are thought to make the virus more infectious, including the DG614G, the N501Y, and the K417N. And this has been published in the New York Times. New York Times also shows us where the Omicron is detected, typically in a traveler, and where you're seeing high levels of local transmission. You can see there's a lot of information regarding Sweden and Britain in the news, in addition to South Africa. But Canada and the United States, we actually have Omicron detected in all 50 states and Washington, D.C. So this is spreading quite quickly. Last week, or a few days ago, actually, on December 20th, there was a news release that said that Omicron variant accounts for 73% of new cases. And on the right panel, you can see the information from the CDC, where week by week, they're indicating what the variant that is dominant, and mostly it had been Delta. And then you can start to see the appearance December 4th. And then by December 21st, you have around 15%. And then by December 18th, you now have 73% or 73.2% that are related to Omicron, with Delta now accounting for 26.6% of new cases. This is dramatic and a very staggering increase in the number of Omicron cases. So I'd like to move on and talk about ways that we are addressing detection as well as treatment of patients regarding specifically with the Omicron variant. This is a study that summarized the use of rapid antigen over-the-counter tests, and they looked at 7 different varieties, some of them which were approved and some of them which were in the process of getting approved. And what they found was that the analytical sensitivity to detect Omicron was lower than for other variants and concerns in most of the tests that were used to evaluate. So the rapid testing that we're doing to detect infection now, when we know that Omicron is dominant, much more dominant, and during the holiday season, our rapid antigen testing may not be picking up this particular variant of concern at a lower frequency than other variants of concern. In one test, the flow flex showed that the highest overall sensitivity compared to others, and it was slightly higher sensitivity than Delta, but lower than Alpha, Beta, Gamma, and the pre-VOC SARS-CoV-2. And you can see the heat map here on the right. The sensitivity or picking up is in the red, and those that are not picked up are in the blue. And this is to the Omicron variant. If we look at vaccine efficacy, so another tool that we use to help with this pandemic, the one is early detections and then isolation. The second is with our vaccines. So this is data that was published or summarized before the appearance of the Omicron variant. And what we found with respect to the 2 messenger RNA vaccines was that there was a high level of vaccine efficacy. The protection waned over time, and you can see that was at the 6-month mark, and that the efficacy improved with a booster and almost up to the initial efficacy. And you can see also in the green, the efficacy for the AstraZeneca vaccine. So what do we know about Omicron? And so this is a study that was published, which was a Danish cohort study. Those who got a 3rd dose of either the Pfizer-BioNTech or the Moderna's COVID-19 vaccine offered a significant increase in protection in elderly people. And what they did was they analyzed data from 3 million Danes that was gathered between November 20th and December 12th. Among those who recently had their second dose, the efficacy against the Omicron was measured at 55.2% for the Pfizer-BioNTech, and it was 36.7% for Moderna compared to unvaccinated people. And then we saw that the protection against Omicron or vaccines waned over 5 months, and it was slower and decreases faster against Omicron rather than when you compare it against a Delta variant after a primary vaccination course. So on this table, you see the Pfizer on the left and you see Moderna on the right. You see the Omicron and Delta for both the Pfizer and Moderna vaccines and days after vaccination. And so you can see the fall in protection against, or the efficacy here in the green, what I've highlighted in the green. But then if you get a third dose of the Pfizer-BioNTech, it restored the protection to 54.6% in those who were 60 and older, and those who had been inoculated 14 to 44 days earlier compared to those who only had 2 doses. So there is hope with the existing vaccines that getting a booster dose would provide some protection against the Omicron. Data from Moderna was not available. There was another Hong Kong study that showed that if you got 3 doses of the Sinovac or CoronaVac, that those who got the third dose of the Pfizer vaccine or those who got 2 doses of either the Pfizer or Corona provides protective levels against the Omicron variant. But the third dose of the CoronaVac given to those who received 2 prior doses does not provide adequate levels of protective antibody. So looking at this graph, you're looking at the titer, you're seeing Pfizer 2 doses, you see CoronaVac 2 doses, this is against Omicron. You get Pfizer, the third dose, and you get great protection. This is your third column. But if you have 3 doses of the CoronaVac or the Sinovac, you don't have protection. But if you get 2 doses of the CoronaVac and you follow it up with a Pfizer vaccine, then you're getting some protection. I wanted to say a word about Novavax, which is what you're going to be hearing in the news soon. So this has a novel platform that we have not seen in the current existence of the available vaccines. So this approach of the Novavax blends new and old techniques. It's a different kind of virus called the baculovirus, which combines the genetic information needed to make a spike protein, a key fragment of SARS-CoV-2. When moth cells are infected with this virus, they manufacture the spike protein. The scientists then harvest and fuse those proteins with a nanoparticle. And these nanoparticles combine with the spike proteins, which is injected into the Novavax vaccine. So you can see these stages right here. The 6 stages are delineated. You have the COVID DNA inserted into the insect virus. That's your spike protein, and then that's the baculovirus. Then they infect the moth cells, and then you have the moth cells that the COVID enters the nucleus. The moth cell is making the spike protein. It's expressed on the cell surface. You make the nanoparticle, which is stage 5, and then step 6 is that this is injected into the final vaccine. So I had presented data regarding the Novavax several months ago. I think this was in June or July that I had shared this. And in the first study in Mexico and the United States, we saw that there was a 90.4% reduction in symptomatic COVID cases. So this is when Delta was present, not when we had Omicron, from 7 days after the second dose in people who received the Novavax. This was 14 cases out of over 17,000 people compared to people given placebo, which 63 were infected out of 81,000 people. So at a 90.4% efficacy. In the second study that was done in the UK, they looked at the reduction in symptomatic COVID-19 cases in people who received Novavax, and they found an 89.7% efficacy. They are doing studies right now with Novavax, I know, with those who previously received other vaccines like AstraZeneca, and the mRNA vaccine. So I think that we should keep our ears to the ground to see what comes of this vaccine. It might provide a mix and match opportunity for boosting if Omicron continues to rage, and it provides a different platform. So this is the initial Omicron cross-reactivity with the vaccine booster, and they did adolescent studies as well. They did a 2-dose primary regimen of Novavax, and there was cross-reactive immune responses against Omicron. A 3rd dose produced increased immune responses comparable to or exceeding levels associated with protection, with a 9.3-fold in the IgG level and a 19.9-fold ACE2 inhibition. As you remember, that is the receptor to which the spike protein binds and enters the cell after the booster dose. The immune responses in adolescents were 2 to 4-fold higher than the adults against a broad array of variants of interest and variants of concern. So again, this is very promising. The anti-spike Ig titers after dose 3 increased 5.4-fold to 9.3-fold after the 2 primary dose. So this is more specific information related to its findings. The ACE2 inhibition titers were 6-fold to 19.9-fold. The 2-dose primary series representing a 54.4-fold and a 24.4-fold to Delta and a 36.3-fold to Omicron. What they said was that after 2 doses, Omicron wild-type neutralization was less than 4-fold lower than prototype, suggesting that both a booster dose as well as an Omicron-specific vaccine may be beneficial. So I think we're still waiting to hear on more, but because this has been discussed now, especially in Europe, you'll be hearing more about this. So let's talk about treatment options. We have monoclonal antibodies and antiviral pills. This has also made the news recently in the past week. And this is intended to keep people newly diagnosed with COVID from being hospitalized. So monoclonal antibodies is also, we've faced some changes in our approach to its use, just as recent as yesterday. So 2 commonly used monoclonal antibody treatments were available to us until yesterday. One was a Regeneron, the Caripivimab with the Endivimab combination, or we had the Bamlanivimab with the Atezolizumab. And what they saw was that there was reduced activity against Omicron, and they have no effectiveness in patients with the Omicron variant. So knowing how rapidly Omicron has been spreading, and knowing that it has shown no efficacy, the use of these monoclonal antibodies have been paused or suspended until further notice, and this was as of the 23rd of December. On the other hand, so Strobomab is a monoclonal antibody that appears to retain efficacy against Omicron. There have been shipments of this particular monoclonal antibody to the United States, but the supply is extremely low, and each state is having to ration its use. I believe in the state of Wisconsin that this has been sent by the state to specific hospitals where the cases are very, very high. There's also a new long-acting monoclonal antibody combination that's being used for pre-exposure prophylaxis for patients at high risk of severe COVID, and this is known as Evusheld, and that just got emergency use authorization. What do we know about the neutralizing activity of monoclonal antibodies and with respect to Omicron? And what you can see here is that the higher the ability to neutralize Omicron or any variant of concern, the number will be in red. And if there is no protection, you will see a white box with greater than 10. What you see with Strobomab is that it retains its efficacy in neutralizing the different variants of concern. And this is the third from the bottom with respect to Omicron. So Omicron, with all its mutations, has escaped neutralization from the family of monoclonal antibodies and their combinations that are available, except for this one particular monoclonal antibody. This is a news from December 22nd. The FDA authorizes the first easy-to-use pill to treat COVID-19 in the US as the Omicron variant surges. So we really now are looking for other therapies. We talked about rapid detection. We talked about vaccination. We talked about monoclonal antibodies, and now we're talking about oral therapy. So what was this pill? This pill is called Paxlovid. This is made by Pfizer. What they found was that there was an 89% reduction in the number of hospitalizations or deaths as their primary endpoint when they compared those who received placebo versus those who received Paxlovid. And the relative benefit at 3 days was similar as 5 days after symptom onset. We saw a 94% reduction in people who were 65 and older. They had a 10-fold reduction in viral load. There were fewer adverse events in the active versus placebo arm, and it showed potent anti-Omicron activity. So again, this is another tool that can be used, but we just need to make sure that there's equity in distribution and access to this medication. It's currently, I don't see it currently being used right now. I think we're still waiting for it to be available. Then we also had on the 23rd of December, Merck's molnupiravir. This received emergency use authorization. This is for mild to moderate disease in adults who have positive SARS-CoV-2 viral testing and who are high risk for progression to severe COVID-19, including hospitalization and death, or whom alternative treatment options are not accessible or clinically appropriate. And with the reduction of the monoclonal antibodies, this really changes the playing field in terms of therapies that are available to our patients or even for ourselves. So based on findings this is also important to remember that this may cause fetal harm when administered to pregnant individuals and therefore not recommended for use during pregnancy. This is the data that they presented. This was a phase 2A double-blind, placebo-controlled, randomized, multicenter clinical trial designed to evaluate the safety, tolerability, and antiviral activity of molnupiravir dosed twice a day for 5 days in patients with mild to moderate COVID-19. So what you see here in the graphic above is that those who are positive are represented in red, and those who are negative are represented in blue. They were divided into those who received placebo, 200 milligrams of study drug, 400 milligrams, or 800 milligrams, and they were looking at visit day 1, day 3, and day 5 from treatment. And the patients who were negative increased by day 5 after they at a much faster pace when they received the molnupiravir. So you can see the data that was released. So again, in summary, we really need to use our Swiss cheese model approach where it's not going to be just one thing. It's not just going to be vaccination. It's not just going to be wearing masks. It's not just going to be about early detection or the use of monoclonal antibodies or oral therapies. But we really need to make sure that we're addressing this pandemic in as many different ways at once as we can. And this holiday season is no exception, as we will have to gauge everything that we do on a case-by-case basis as the world is surging. I want to thank you for your time and attention.
Thank you, Dr. Monica Vasudev, for a wonderful insight. And now we will open the forum for the question answers. I'm sure there are a lot of questions been waiting as we have been missing her for a while. So let's go for it. Dr. Chong? Yeah, I saw your hands coming up. Yeah. Yes, Dr. Chong.
Yeah. Thanks, Sarah. Thank you, Monica, for that wonderful presentation. And just a quick question. This propensity to infect younger people, as observed by Dr. Angelique Kuzi in the beginning of the Omicron outbreak in South Africa, are you seeing this in the United States as well? And if so, is there any reason behind it other than just behavioral?
So you're asking if we're seeing the same observations that she did, that the disease is spreading fast, that there's less hospitalization rates, that there's milder symptoms, no more headache, less nasal congestion, less anosmia. Are those the features that you're asking?
And also, she mentioned the patients were mainly below 40.
So what we are seeing locally is still a surge of the impact of Delta. So this is like in the last week that we're seeing that the Omicron you're picking up cases. So the patients that are positive and are probably Omicron detected, they're not coming to us to say, I'm feeling sick. So it's going to be in the next 2 weeks that we're probably going to see whether or not, but everyone who's been hospitalized right now is pretty much Delta. So these are all new cases. So from the time of new cases to the time that we're seeing symptomatic, more morbid mortality, it takes some time. So I don't think we're there yet.
Do you think there's a possibility that because the Omicron seems to multiply faster, replicate faster in the bronchioles, and the Delta seems to replicate faster in the lung parenchyma, do you think that this differential may lead to some sort of synergy, as in, for example, I understand that some places they are separating the Omicron and the Delta patients apart. They're not allowing them to be housed together in some manner. If you understand what I mean, is there some kind of interaction between the two viruses? For example, is there a possibility that both may infect one patient at the same go?
So that's a really, really interesting scenario, because I will have to draw back from basic virology.
Sure.
And when you get infected and you make interferon gamma, then typically you do not get another viral infection at that time. But this, I feel like we're in a scenario where we're watching a very novel process.
Yeah.
And it would just be incredibly unlucky to have something that has the predilection for lung parenchyma and then something that has a very, very strong predilection for the bronchus. Yes. Yeah. It just seems not good.
Yeah. I was thinking when I saw that slide on the the lung parenchyma versus the bronchioles, that whether these sort of weird scenarios or some sort of synergy or whatever will happen between the two variants. I was quite worried about that. I mean, they compete with each other, but who knows? They may work together, if you know what I mean.
Yeah, but you never know. The mutation, the next Omicron mutation, might develop the features of Delta. They already have some shared mutations. Yeah.
Dr. Akhtar has a question, I think.
Thank you, Monica. Thank you very much for the information. I just wanted to know about Johnson & Johnson and Omicron protection. Thank you.
Yeah, that's a great question, because they actually paused the Johnson & Johnson, stopped recommending Johnson & Johnson because the efficacy was very low on this. I can look and see if there's any data right now. Yeah, so it says, at least that there is no antibody response to Omicron with Johnson & Johnson. This was as it was studied in South Africa.
Thank you. Thank you.
Saurabh?
Yeah, Dr.
Saurabh, yes. Can I ask, Saurabh?
Yeah, go ahead, ask your question.
Okay, thank you very much. Excellent presentation, Dr. Monica, as usual. I have two questions. Number one is, as Dr. Angeli Kurzi said that they have found the very mild to moderate symptom in the Omicron patient, and the one symptom she mentioned is the fast pulse rate. So, do you have this type of symptom in USA? Number one, and if you find what is the treatment of these type of patient with fast pulse rate? And the second question I have already asked a few, I mean, one couple of months back, that about the vaccine. You have said the single booster dose of Pfizer for the elderly patient is very good. I have read somewhere in group and literatures, and in Pakistan, I have seen the health workers also having the second booster dose. Is it good to have a second booster dose of Pfizer? Thank you.
Okay, with respect to your first question on looking at the tachycardia that might be associated with the Omicron, I have clinically not seen cases of the Omicron yet. That might be because of how it is spreading in the country. I don't have any, all the cases of the infections that I'm seeing right now are still related to Delta. We, with respect to the fourth dose of the booster and those who have received other vaccinations, obviously there is a recommended schedule on these immunizations, but due to the fear of Omicron and the fear of lack of efficacy of one type of vaccine platform against another, if people have received 2 doses of a mRNA vaccine, which followed a vector-based vaccine, from anecdotal conversations and knowledge, I know many, many people who have received 2 doses of Pfizer within the US who came here from other countries where they were receiving primarily the AstraZeneca vaccine, and they did get both the dose series when they came here instead of a single booster. And that was even they were receiving the 2 doses even in summer. So of the people, individual conversations and cases of people that I have discussed this with, they had all tolerated the 2 doses of the vaccines, the 2 doses of the booster vaccine of a different platform compared to their initial series.
No, do you have any expert opinion that the 2 booster dose, like in Pakistan, we have the Chinese vaccine, the Sinopharm and the Sinovac, and after having these 2 vaccine, after 6 months, they have the booster dose of Pfizer here in Pakistan, and then people are having the 4th dose after 1 month. So, is it a good to boost the immunity against the coronavirus? Do you think it's good, or it's a single dose booster is enough?
The study that I had shown in the earlier slide said that the single Pfizer boost from an initial Sinovac showed efficacy, but it wasn't as high as the original 2-dose Pfizer series. It is speculation on my part, but I do believe that it would be beneficial.
Okay, thank you very much, Monica.
Yeah, you're welcome.
Dr. Chaudhary?
Yeah, thank you. Sorry, I was late actually today. Just Dr. Monica, do you or any other can answer? That is, WHO is just telling that yes, hospitalization and the critical illness is less in case of Omicron so far shown. But what about the moderate cases? Do you, if there is a moderate case, so don't you think that it will have some sort of impact, long-term impact, or something that it may have to somebody? So that we should warn, actually, rather should not allow them to go infected, because yesterday I've seen it's more than 100,000 in infection in 119,000 in UK and more than 100,000 in US. So I don't know what impression we're giving. If you consider the case regarding the post-COVID, whether moderate case also keeps some sort of imprint on that. I don't know. This is number one question. And number two is about the molnupiravir, which Mark has has produced Mark. And Mark initially they claimed that it is more than 50% effective. After some days, they say that it is only 30% effective. So what about the impression? What about your impression that whether this molnupiravir should be continued as a treatment? Because it's only 30% effective, they are claiming now. So in our country, several companies actually have been given the permission to produce this medicine and it's in the market. So what should be the message from our side for this paper? Thank you.
Okay, so with respect to your first question, thank you so much for your questions. When you're looking at the percentage of people who are getting infected and the fraction of those people who are getting very sick, moderate to severe disease, if the denominator is huge, even if the percentage or fraction of that is small, you're still going to have a significant number of people that will have moderate to severe disease, because the total number of people who are getting infected are going to be much more. And I agree with you, even if it's mild disease, it does not mean that you're going to completely recover and it's just going to happen and go away without leaving some sort of imprint. I do agree with you. And it is very, very important, even more so, because the more people that get infected, the more the virus has a chance to mutate again, and all the people that are infected. So we're just going to continuously propagate. So we just need to be able to stop and prevent the infection as much as we can with the tools that we have. Now, with respect to the Merck data, if the efficacy has gone down because the data was relooked at, because they looked at a different population, because they expanded the population, even if the efficacy goes down from 50% to 30%, that is still 30% efficacy, right? When we don't have a lot of tools. We do not have a lot of tools now. We had monoclonal antibodies until yesterday. I'm still on 24th. So on 23rd, they took away the monoclonal antibodies. So it's not a completely benign drug. I talked about the fact that it should not be used in pregnant women. But I think that if you have someone who is early in their course of the disease, they have risk factors for mild, moderate, or severe, for moderate to severe disease, even if they have mild infections up at the front, I think it's definitely worth it. If you knew that you were infected and your symptoms were mild, but you have risk factors, whether it be age, whether it be obesity, whether it be any other conditions, even if it gave you a 30% chance of getting better and you had access to this drug, would we not all take that drug? I would.
But you know, this Pfizer is claiming 80% effect with their medicine, this Paxlovid. So why to choose this one?
I don't think we're going to have a choice. I think it's going to be whatever's available at the time that you're infected. These are drugs that we've gotten information about. These are drugs that are showing some efficacy. We're going to see better data as time goes on and as more people are being tested with Omicron. So this is very preliminary data. And I feel that at least we have two different tablets, two different companies. And when you get infected, you have no control over the time that you get infected. It's just going to be a matter of when, right? The entire world will potentially get infected, whether it be during a pandemic or when it becomes endemic. So we have to be able to understand what are the tools that we have right now. And I understand that it's disappointing to see a number drop from 50% to 30%, but I still think that 30% is still better than 0%.
But Dr. Monica, FDA approved molnupiravir?
Yes.
Thank you.
Yes. No, not a full approval. It received authorization.
Dr. Monica, may I ask?
Yes.
Please ask.
Yeah, I'm Dr. Agarwal from India. I'm a nephrologist, but I just want to take your opinion on from a public health perspective. You see, we have got limited drug efficacy and the vaccine efficacy on the new mutant viruses. And with the spread, we are expecting that there will be further mutation. And people are fed up for last 2 years, and we are seeing the compliance in terms of a primary prevention, in terms of a mask and hand hygiene, are decreasing with passage of time, and people are resistant to follow. So with this scenario, there is chances of a more spread and more mutation is likely to be there. Considering all these things, where you are seeing where the world is heading in terms of a next 2, 3, 4 years?
That's a great question. So I looked before November 27th at a pandemic that was probably going to peter out in spring, summer of 2022. I do not see that at all. Right now, as we are still dealing with the effects of Delta in the US, we are now seeing the Omicron spreading everywhere. Like I had mentioned earlier, 73% of new cases from last week are all found to be Omicron. I know that our hospitals are full. I know that our hospitals are not able to absorb all COVID and non-COVID cases. I know that supply chain issues for things that we expect to be available is not available. And I don't know what 2022 is going to bring. I feel hopeful that these boosters are showing some efficacy. I feel hopeful that we have some oral therapies available. I feel hopeful that there's a monoclonal antibody that is shown to have some efficacy. These are small pieces of hope to hang on, but I also realize that these medications and therapies are not going to be available worldwide. In India or in the rest of the world, where all of us are experiencing pandemic fatigue, I do not know. I don't know where we're going to be. I know that we're all tired and we're going to continue to be tired. Whereas we have to continue to learn new information, and we're going to have to process new information, and we're going to have to counsel patients. But I hope that if this is the worst before it gets better. And all I can say is that we all just need to hope and pray that we stay well, that we make the right decisions when we come to it, and that we have the resources and tools in our toolbox to be able to address our patients. I'm sorry, I don't know.
I just want to share our total academics in nephrology has totally changed. We are not able to do transplant as regularly. We are having difficulty in handling the dialysis population. We are having difficulty in those patients of nephrotic syndrome or other things who have got a recurrent requirement of coming to the hospital. Our research is affected because patient follow-up and inclusion in the research trial. So everything is very much disturbed, and we are not sure that in a immediate near future residency scheme and training of the resident. So it has got so much wide impact on medical profession itself, not on patient care, but as such other aspect of the medical education and the research that you feel lost that what we are heading to.
We're all mourning the loss of the life that we knew, and we're mourning the loss of opportunities and mourning the loss of how science and medicine has paused. And for all those patients that are looking for alternative renal replacement therapies or even just dialysis, I understand what you're saying. It's the quality of life is everyone's quality of life has been affected, not only the patients but their families.
Thank you. Dr. Jang, can you quickly ask your question?
Hi, thank you for the question. Thank you for the talk. Wonderful. I just want to ask, with the authorization of the 2 new pills, do you foresee the monoclonal antibodies being replaced in the near and the long term, or do you think that those therapies will complement each other in the near and long term? Thank you very much.
Oh, great question. So I believe that there will be complementary. I believe that the distribution of the availability of these therapies will be based on need and geographic location, and in terms of access to healthcare. Monoclonal antibodies will be obviously available in the big hospitals, but if you go into peripheral areas, then oral therapies will be necessary. One of the monoclonal therapies was a pre-exposure prophylaxis, might be used in healthcare providers who have multiple healthcare conditions. But I do believe that it's going to be multiple things that will be in play. And I'm glad to be able to see an assortment of therapies that could be available.
Dr. Nidhi Dhawan, you want to ask a question? So she has a question of out of 72% of the new cases,
Yeah.
how many are symptomatic?
Yeah, Saurabh, I would first like to compliment Dr. Monica on an excellent presentation. I have two questions. One is going by what Dr. Angelique has been saying. It does appear like the wave peaked very fast, came down very fast, and now we are seeing almost the end of it. Also, that it did not require hospitalizations. Mostly the cases were incidentally found. So of the new cases that we are seeing in the US, how many are symptomatic? And or are you seeing the same picture, that they are incidental discoveries? And if it is escaping monoclonal antibodies, and the target is still the spike protein with the old spike profile, how come the new boosting is working? Thank you so much.
These are great questions. So in terms of the percentage of the 73% of new cases that are detected, how many of them are symptomatic? It is not clear. What we do see is that there has been around a 10 to 15% decline in hospitalization rate in the past week. I think it's too soon in the US to know, because we are just seeing the rise now. So what we see is that there's a rise of infection, and then we see the hospitalizations that follow like 10 days to 2 weeks later. So I think we're going to start seeing this in the next week in terms of people who are going to be very sick. And that is a fantastic question about why the monoclonal antibodies are not working, yet the vaccination boosting is. That is going to be probably come down to the actual sequencing of the mRNA in terms of what part of the spike protein was included in the vaccination. I don't have that answer for you. I didn't look into that detail. I just heard about this new pause on the monoclonal antibodies yesterday, and I was actually quite surprised because some of my patients were scheduled for infusions yesterday itself. So these were patients who were moderate to severe asthmatics, or they had other lung conditions like COPD or bronchiectasis, and they had a positive COVID case because they were symptomatic and they were going in for the infusion. Now, in that case, they were probably Omicron cases, right? Because they were coming in the past several days. So I think that the information is rapidly emerging and changing, and I don't have the data that's been published or reported yet to be able to give you those answers. But I will try to go back and try to find to multiple different parts of the virus compared to the mRNA vaccine, which is very, very specific. But I don't know, or I don't have enough knowledge to be able to tell you why the boosting is still efficacious. Maybe there's some non-receptor binding proteins that are included, or there's some cross-reactivity that is showing, that is helping with the with its efficacy.
Which, I mean, defy the science and the logic. The logic would be that if the spike has changed so much, then the old platform would not be so efficacious, but it is showing to be. And if the spike has changed so much, then antibody response to other components of the virus should improve the vaccine response, which we don't have data for. Thank you so much. Thank you.
Thank you. I agree with you.
Monica, so
Yes.
in that case, actually, I understand that the word boosting is a sort of a bit of an understatement, right? Because when you actually boost when you actually give a booster jab, it's not raising huge response from all the different parts of the immune system. Is that right?
Yes, but the antigenic component is going to be fixed. But yes, you'll get B cells and T cell recruitment and memory. Yes, as opposed to monoclonal antibody, which is kind of a Band-Aid treatment where you're just getting yourself antibodies. But I think her question is actually quite fascinating as to why a specific mRNA vaccine with a very specific antigenic portion has preserved its efficacy with boosting, whereas the monoclonal antibodies have not. And I think it might be just a function of what the actual antigenic recognition is. Yeah.
Dr. Monica, we all know that Omicron is like a milder version, but people who have a long COVID and have been still affected and have still issues, and people who have patients who have comorbid disease, if they get infected, is that still they have to look into the early testing, early vaccination, early medicines or something? Or is that a concern for them, a major concern for them?
So if you have 100 people who get Delta, and we're just going to make these numbers up, and 40% of them get really, really sick, versus you get 100 people with Omicron and 5 people get really, really sick. If you only get 100 people that get infected with Delta and 500 people that get sick with Omicron, you're still going to have a lot of people who get very sick with Omicron. So if you have risk factors and you get Omicron, you have no idea if you're going to be in that 5 or not bucket, but you're one of many, many people. So from a population, from an epidemiological perspective, yes, you need to approach infection, whether it be Omicron, whether it be Delta, the same way. You have to, keep yourself isolated. You still have to go through the process of making sure that you're treating all your comorbid conditions. For example, if I have asthma patients, we all know that adherence to medications is like 75-80% in terms of people using their inhalers. There's a twice daily dosing. We know that they don't remember to take it, some of the times. But if they're sick and they know they're sick and they're not very sick yet, they have a mild case and they continuously need to take their medications. In terms of long COVID, I think we don't know yet what the chance of getting long COVID from Omicron is. I think that there's still a boatload of information that we need to learn about how to treat our long COVID patients. Each of our patients with long COVID have all absorbed a different symptom, whether it be anosmia, whether it be dyspnea on exertion, they're short of breath. I think that we don't know. We still need to know more. I wish I knew how to treat my long COVID patients. All I used to tell my long COVID patients is that if you get the vaccination or if you get boost, there's some word that maybe your symptoms can get a little bit better. And anecdotally, my patients tell me, yes, I feel 10% better. I feel 15% better. But I don't think it'll be any different with Omicron. And as time goes on, as Omicron further potentially mutates, the initial data that we saw coming out of South Africa may not be the case of what we're seeing in our local areas. So we have to be vigilant again to understand what is the pattern of the infection in your local areas.
But Dr. Monica, just one thing, you are just pointing out that it's proportionate to the number of infections who will be severe or critical. But why it should be rational to just define it that way, that yes, in case of Omicron also, we have to do it in a proportionate way, or you have to just think of the proportion of the number of infections who will go for hospitalization. Why?
We do that because we're trying to ration healthcare resources.
No,
right?
no, I'm not telling that. I am telling that because, in Delta or Alpha or something like that was actually, we are knowing that yes, some sort of 1.5%, something like that will go for the critical illness, or 0.5% will go will be dead, something like that. Okay, but why we are thinking that was actually because of this researches have gone, studies have gone, and that we came to this conclusion. But in case of Omicron, it's not the same thing. So you are telling that the number of infections decide how many people will go for the hospitalization. It's not the picture now.
No. I'm just saying that, of the people who are infected, there will be a few people that will get really sick. And the more people that get infected in general, the more people will get sick.
But the percentage is not as true as Delta, because we
I was just using that as an example. That was not, I was just being hypothetical about that. That was all I was trying to say.
But another thing that Saurabh was telling, this mild cases, it's like, do you think that it doesn't cause a moderate case also? It goes for it. Just we are talking about the hospitalization only, but we are not talking about the moderate cases also. Where Omicron also gives rise to moderate cases also. Moderate conditions. So that means that the lung is infected. That is, there is some imprints in the lung. That is the moderate case. Okay?
Yes.
So we are not cautioning, and we are not talking about these moderate cases, because you may have some sort of problem in your lung, and that may create some problem for you in the later time. It may not be cured 100%, or you may go for post-COVID, you may have some problems for that. So that way also we have to caution, because now everybody is telling, oh, no problem, we will not go. It doesn't increase the hospitalization. So not to worry. Why not to worry? The people are telling, because the WHO is giving this message.
I completely agree with you. Absolutely 100%. I think that is a fantastic point that needs to be raised, is that we cannot drop our vigilance. And Dr. Dovan, I also agree with what you said too, that the modeling for the Omicron must be different. And this is all part of what I was trying to say earlier, is that we cannot drop our vigilance. Like, we cannot assume that just because there's a few people, of a group that get really sick, we have to assume that any person who gets the infection has a potential to become sick. So we have to go through all the pieces. I think we're all saying the same thing. But again, we're so early, and I'm so glad that Dr. Kotze had reported this in the beginning, because we're in a much different place of understanding about how to move forward with this than we were when the pandemic first began. But I think we're also, ideally, we would love to have all therapies available at our disposal when we find out we're positive, so that we can choose the best thing at that moment. And I don't think that that's going to happen. I know that I had patients that I wanted to get them monoclonal antibodies, and I felt that they had risk factors, yet when they went to the place to get assessed for monoclonal antibodies, they were off by a day or two of onset of symptoms, or they didn't meet criteria. So I would love it that we could all get the best therapy to reduce risk in every single person who's infected, whether it be Omicron, whether it be Delta.
Do we have anyone else? Yeah.
Saurabh, can I come in? Thank you, Monica, for updating. New protocol came up in South Africa 2 days ago. COVID-19 protocol is now asymptomatic positive patient, we don't need to isolate. Only the mild and symptomatic patient we isolate now 8 days. Moderate to severe, we isolating 10 days, whether you're vaccinated or unvaccinated. There no need to quarantine contact of positive patient, including family. Also, we started now, no need to contact tracing or testing asymptomatic patient. So, Dr. Monica, you think we are doing the right thing?
I think small opinion, and in line with the conversations that we're having right now, I don't think so. I think this virus we are underestimating the potential of this virus. And what they had seen in South Africa was a South African experience of a month ago. And what we have seen is this virus is constantly evolving. And I know that people are fatigued with the pandemic, and that's what I hear with the people making these policies, is that the population needs to go to work, needs to go to school, and needs to be participate in the economy. But I think that all of us, or most of us on this forum and right now, feel that that is probably not ideal.
Monica, can I ask a question about, the numbers of Omicron are going to be huge, it looks like. So I remember the data on children. 2 million children in the United States were infected, and 8,000 were hospitalized. A third went into ICU, 94 deaths in 5 to 11 years old. This was the data that was presented when they were authorizing the children's vaccination. And something like 7 to 8% of the children had long COVID, and the Kawasaki's disease or multi-inflammatory syndrome in 5,000 cases, 60% admitted to ICU. So looking forward, I think these numbers are quite scary. Do you see this becoming a huge problem? Because it looks like also the virus is spreading among the younger age group rapidly. I'm not sure whether it's physiological or it's behavioral.
Dr. Chong, I sorry to interrupt you. How many deaths you have mentioned in United States with Omicron? Only Omicron.
No. This was the data that was presented previously. I think most of it was Delta and the previous variants.
Okay. So I just want to know from Monica, how many deaths from Omicron? Do you have any data, and how many children are in that?
I do not have any data regarding this at all.
Okay.
There was one that they had reported that was about 4 days ago that they thought was believed to be the first death in the US, and that was in an adult. But if there's any new data in the last 3 days, I'm not sure, and I don't know how the holidays are affecting reporting right now. So I think that's part of the issue too, is that I don't know where we are with some of the questions that you are asking. We're very, very early.
Okay, if I can say, or I can just give a message to anybody that the Omicron is not a problem. The problem is the coronavirus. The bottom line is that we have to protect ourselves from the coronavirus, because the people are very much scary and asking about how to prevent us from the Omicron. So there are lots of things coming in the media that the Omicron is very dangerous, spread very fast, and it can done anything. So be careful. Everybody is scary. But my point is that the Omicron is maybe in future can harm the public, but we should give message to the general public that the SOPs which is being said from the very beginning, that the people should follow the SOPs and get vaccinated as early as possible. So this thing can be protect to any variant also, isn't it?
That is true. I think why I had said what I had said earlier was because we had reported that 73% of all new cases in the US was due to Omicron. So when you have 73% that replaces Delta, and we've seen what Delta is done, let's see what happens in the next 2 weeks and see where we are before I agree making it too alarming. The reason that maybe some of the alarm was raised was because of these holiday season, and that people were being discouraged from traveling and meeting, especially other family members or gatherings where people may not have been vaccinated. And also, this is all happening at a time when now we don't have monoclonal antibodies here as well. So there's a lot of different variables that have been affected right now. But in terms of SOPs that do not require isolation for those who are positive. Now, that non-isolation or isolation is, well, do you wear a mask? Are you interacting with others? Maybe Omicron for the regular with no factors, risk factors, is different from those with risk factors. We don't know. I think we just need to wait. I think a lot of the questions we have is going to solve itself in the next few days to weeks, and especially as we get more data that's reported after the holidays.
Right, you're right. Thank you very much, Monica.
Yeah.
So Dr. Monica, this question which I have is pretty relevant, majorly for Indian side of it. So what is happening in India currently is, let's say there's a gathering of about 50, 55 people or 100 people. And one of them randomly is just traveling outside of a different city and get tested in a border, and he gets positive. It doesn't matter which variant, but he gets positive and he has no symptom at all. But he have met a lot of people there, and most of them are asymptomatic, not even a sneeze or something which is going around. And most of them, others, are not getting tested because they say we don't have symptoms. Why are we going and picking our nose? We will not go and test it. So what's going on is these people are not testing and they are meeting other people around. So what is it that, people should do here? Because this is something which is unavoidable and unstoppable. And especially when the Christmas and New Year is around, people are meeting each other. And some of them has allergies for, winters, or pollution is there. Some of them are just coughing randomly, which says, oh, this is just an allergy which I have every year. This is a greater concern which is going around. People are getting very, very, again, they are getting into a stage where they're getting very finicky about it and meeting people. But again, it's not avoidable. You can't be getting tested every time, just because you're going for a function or traveling. You can't do that. We talked about this before the start of the event. Is there a message for that?
So in the US experience, we do not have availability to testing rapidly. There are people who are looking for the over-the-counter test. We have one brand called Binax now. We get it at our local retail pharmacy called Walgreens. And these tests are flying off the shelves. There's nothing available. So we don't even have testing available when we want testing to occur. We have people who can get a common cold. We have people who have allergies, many with multiple symptoms. So the first question is a person who is asymptomatic gets picked up with a positive test, right? Now, that's assuming that that's a rapid antigen test versus a PCR test. Maybe it's not, it's positive. And I agree with you. If I see patients who come to my clinic, and I found out the next day or the day after that they were positive. Now, I was exposed to the patient. I'm masked. The patient is masked. If I don't have symptoms, I don't test just because I had an exposure. In the setting of a wedding, when you have two people who are unmasked and you find out that one of them turned positive, if that person was asymptomatic and the person who was standing next to that person was asymptomatic, they'll only test if they're symptomatic. So even if they have allergies, but they were next to a person who was known to be positive in that encounter, then get tested. But if they think that this is not allergies, because there's a feature that's different from the routine symptoms, then go get tested. So we have to kind of have a balance, right? In terms of what is the symptoms and are they different than your normal symptoms? So I know that Omicron isn't associated with a loss of sense of smell like the other variants are, and that it might be difficult to tell that there's headache and there's fatigue, which are common symptoms that you can get with many virus infections. But the issue is that the minute you suspect that you have an infection and you can't get tested, then isolate yourself.
And is there a protocol which has come up like day 0, day 1, day 2 in case of there is I remember Dr. KK used to do that when Delta came up. So what a person should do in day 0, let's say, or day 1 or day 2, and which day is severe, which day should be watched out, which day should be not ignored.
Right. So this is a different pandemic than Delta. So we still have to wait and see what happens. And if you're asymptomatic then you just continue to isolate, wear a mask, make sure that you're not spreading to others. Because if we really want to end this pandemic, we have to really make sure that mild, moderate, or severe, that we're not spreading the virus, where every time you spread the virus, the patient who carries the virus has a chance for another mutation for occurring. So we have to stop the transmission as much as we can.
Dr. Monica, what is the percentage of the moderate cases in case of Omicron? Do you have any idea?
No, I don't. No.
Okay, so do we have more questions, or should we let the speaker sleep for a while? I think it's too late for her, and it's a Christmas morning for her. We are being selfish asking questions again and again, but this is something which we are very thankful for her to come in, and especially it's a last show for this year. So this is actually a happy new year for everyone, including the Christmas. So should we do we have any other questions, or should we just wind up? Dr. Chong, should we wind up? Okay.
Go on.
Okay.
Yeah, I think we should wind up and let Monica enjoy her Christmas Eve, or what's left of it. Thank you, Monica, and most kind of you always. I wish you a Merry Christmas to you and all your loved ones at home, and your family and your extended family and your clan and so on. So have a good festive season. Enjoy your Christmas tomorrow, and and your New Year subsequently. And we look forward to hearing from you again soon.
So I would say, Dr. Monica, can we close this year with your message of 3 people? Like we all know we have been hearing out, but I think this is the last message on this CMAAO platform. So can we have a message from you, Dr. Chong, and everyone? Perfect. A message from you to everyone, and this is also for non-doctor.
Yeah, so I'd like to say thank you to everyone, and for kind of conversation. We need to continue to have conversations in Dr. KK Agarwal's legacy. I think we need to remember to use common sense with everything that we do, and that we should trust the science that goes behind the recommendations. We can always question and we can always judge things, but I think in the moment, if we did what we all should be doing collectively, we can all feel proud in doing our part to bringing this all to an end. And I hope all of you stay well.
Thank you very much. And here, what a brilliant message. Thank you so much, Monica. And you've summed it up so well. Couldn't better that. Thank you.
And Dr. Monica, thank you for joining this platform. And I think it's a special thanks from CMAAO and Heartcare for you to be here and giving us knowledge, enlightening us, and all the associations to be a part of it. With this forum, we are getting a lot of information, and this is a very, very helpful forum. So with this, we will continue in 2022 and wish you a very, very happy New Year, everyone. I would like everybody to unmute themselves and say Happy New Year to everyone, and then we'll close the session.
Happy New Year.
Merry Christmas.
Happy New Year.
New
Year. Merry
Thank you very much. Happy New Year and Merry Christmas.
Merry Christmas.
Happy New Year.
Thanks,
Merry
Amelia.
Christmas and a Happy New Year to everybody.
Thank you so much. Thank you so much.